Hello, this is Alan recording for the virtual lab demonstration. The first position that I have to demonstrate is the AP hip. So for the AP hip, the patient is on supine position. For this one, we have to use the grid. The SID is 40 inch, and so now for this position, we have to rotate the leg 15 to 20 degree medially. This one to place the femoral neck in profile with the image receptor, and as much as we can provide the comfort to the patient so that he will not be moving because of the hard surface or discomfort. So after this, the CR will be perpendicular to the mid-sagittal plane of the body, and will enter 2-inch will enter at the level of the femoral neck. But to see where is the femoral neck, we have to check the AIS, the axis. Yes. After the axis, we have to check the pubis. From the pubis, we go 2.5 inches laterally. Then we can go exactly at the femoral neck. This is where our CR have to be perpendicular. For this one, we have to suspend upon full expiration. And the KVP for this one, the KVP is 85. For the mass, if it is a CR plate, the mass will be 20. But if it is a digital plate, it will be 10. The structure that will be shown here will be the head of the head, the neck of the femur. We also see the greater trochanter in profile, and the proximal femur are also shown. The femoral neck head seen inside the acetabulum. We will see the entire long axis of the femoral neck not foreshortened, and the greater trochanter, like I said before, in profile. But if it was a patient that was in trauma and cannot move or had a surgery, this one we could have used a plate that is 14 by 17 instead of 10 by 12, because that one the patient could not move. Okay, this is to do this. I have to put the plate. When we put the plate have to be placed so that we make sure that the top of the plate have to be superior to the axis, and laterally at the border of the spine, and the inferior part have to be contain the maximal at least three part of the proximal femur. This marks the end of the first part. To go straight for the second part, the second part is the AP oblique femoral neck. This is the unilateral femoral hip that we also call front leg. So for this one, the feet of the patient we have to flex the feet and rotate it laterally up to 45 degree, like this. Yes. So that's say we have to adjust the patient center axis at on the affected side to the midline of the grid. Flex the hip so that the planters, the foot of the patient have to be at the level of the knee of the unaffected legs. So after this one, the CR have to be at like we said on the first of the APE hip, the CR have to be perpendicular to the center of the mid-sagittal plane, and entering will be enter the body at the level of the femoral neck. And as I said before, to check the femoral neck, we can just go, we check the axis. After we check the axis, we check the pelvis, then we can go 2.5 inches laterally, then we are right to the femoral neck. Then here, for this position, the patient is still supine. We use a grid of a 14 by 17 lengthwise. The grid, yes, we use the plate of 14 by 17. The grid, yes, we use the grid. The SID is 14 inch. The patient can be a little bit rotate. This is okay. The patient have to suspend at upon full expiration. The collimation is 14 by 17 lengthwise. The KVP will be 85. The mass for the CR will be 20, but if you use a digital plate, it will be 10. For the structure that is shown, it will be, we will see an AP oblique projection of the femoral head, neck, and trochanteric area. The femoral head, neck, and acetabulum are completely shown. The lesser trochanter view on the medial side. The femoral neck without superimposition of the greater trochanter. This is to show that maybe this is no rotation. If there is no rotation, this is what we will see. Okay, I think this is the end of my demonstration. Thank you. See you for the next one.